Hello and welcome to today's class. Today I'm going to discuss on meningitis. Meningitis is inflammation of meninges which is surrounding the brain and the spinal cord, and this is one of the common infection occurring in children. Meningitis can be viral, bacterial, fungal. Out of these, viral meningitis is commonest, but bacterial meningitis is more serious and life-threatening. So we'll be discussing in detail regarding bacterial meningitis today. Fungal infection or fungal meningitis can occur, but it is not so common, it is rare. It usually occurs in immunocompromised children. So let's start with the definitions. Meningitis is inflammation of the leptomeninges, that is pia and arachnoid matter, which is covering the brain and the spinal cord. And sometimes it involves the dura mater also, so that time it is called pachymeningitis. Now let's see what encephalitis is. This is inflammation of the brain parenchyma with cerebral dysfunction, and this is more serious. Meningoencephalitis. This is inflammation of the meninges with brain parenchyma. So usually many times we get meningoencephalitis where both the meninges and brain parenchyma is also involved. There is another term known as encephalopathy. So this is a broader term which refers to cerebral dysfunction occurring due to many causes besides infection. So it can be due to toxins, metabolites, poisons, infections, and some inflammations due to other conditions, and lack of oxygen like hypoxic ischemic encephalopathy. So all these are different causes leading to encephalopathy. Now let's come to classification. How do you classify meningitis? So based on the duration of illness, it can be acute meningitis. It is acute when it is lasting for less than 4 weeks, that is less than 1 month. This is again subdivided into acute, that is 1 day till 1 week is called acute, then subacute, that is after 1 week till 1 month. Then comes chronic meningitis. So meningeal inflammation is persisting for more than 1 month or 4 weeks is known as chronic meningitis. And another term is recurrent meningitis. Here there is occurrence of the multiple acute episodes of meningitis, each lasting for less than 4 weeks duration. Now based on organisms, meningitis can be acute pyogenic meningitis, that is bacterial meningitis, which I'll be discussing in detail today. And then acute aseptic meningitis, that is viral meningitis. Commonest viruses are enterovirus, after that herpes virus, mumps and measles virus. And there are chronic meningitis also. So in example, bacterial TB meningitis, parasitic malarial meningitis, amoebic meningitis, toxoplasmosis. These are not very common. If it occurs, it is almost life-threatening. And fungal meningitis occurring in the immunocompromised children, candidiasis, cryptococcal or histoplasmosis. So let's see acute bacterial meningitis. This is common in neonates and infants than the older children, because the younger children, they have immature immune system. Also it is most potentially serious infections having a high rate of acute and chronic complications. And the incubation period for bacterial meningitis is 2 to 10 days. Always remember and always consider meningitis in children who present with fever and has some CNS signs. Now come to etiology of the bacterial meningitis. We'll discuss bacterial in detail. So depending upon the age group, there are different causative organisms. Neonates, in early onset, group B Streptococcus, E. coli, Klebsiella, Listeria monocytogenes are common. Late onset, E. coli, Klebsiella, Listeria monocytosis and Staphylococcus organism is more common. 1 to 3 months of age, E. coli, Streptococcus pneumoniae, Haemophilus influenza and Staphylococcus aureus is common. 3 months to 5 years, Streptococcus pneumoniae is commonest, then is Haemophilus influenza B, but with the vaccination the incidence has decreased, and then Neisseria meningitis. And more than 5 years it is Streptococcus pneumoniae and Neisseria meningitis. Now let's see the predisposing factors with the causative agent. And these predisposing factors are also the risk factors. So whenever there is CSF leak, altered mucocutaneous barrier in the cubriform plate with the damage, if there is a middle ear infection, then Streptococcus pneumoniae is common organism. CSF shunt, neural tube defects, septic foci in the skin, lungs, bones, trauma, fracture, base of the skull, osteomyelitis, then Staphylococcus aureus, Staphylococcus epidermidis, and gram-negative enteric bacilli are commonest. T lymphocyte defects, Listeria monocytogen infection is common. Defect of complement system like C5 to C8 and Properdin system defect, there is recurrent Neisseria meningitis infection. Young age and immunocompromised gram-negative organisms are common. Splenic dysfunction, asplenia or sickle cell anemia, streptococcal pneumoniae, Neisseria meningitis, Haemophilus influenza. Capsulated organisms, these diplococci are more commonly seen. Now come to transmission. It is transmitted through respiratory tract secretions or the droplets from person to person. And whenever there is overcrowding, even close contacts can lead to transmission of infection. Now let's see the different routes of infection. So it can be direct implantation from skull bone fracture after trauma. It can be due to congenital defect like neural tube defect, especially the meningomyelocele. And contagious infection can occur whenever there is infection in the surrounding areas like paranasal sinusitis, otitis media, mastoiditis, orbital cellulitis, tooth abscess, cranial or vertebral osteomyelitis. Hematogenous route spread can occur after pneumonia, bronchiectasis, bacterial endocarditis, pyoderma, septicemia, septic foci in the skin, lungs, bones, viremia and fungemia. And there can be retrograde transmission after herpes zoster, rabies or varicella zoster virus infection. It can be iatrogenic after lumbar puncture doing the procedures. So lumbar puncture, ventriculoperitoneal shunt, cochlear implant, or cranial or vertebral osteomyelitis. Some of the common risk factors are age. Younger age are at more risk. Under-vaccinated children, immunocompromised child, children living in the crowded conditions or have in a low socioeconomic status, if there is a CSF shunt or CSF leaks, and congenital vertebral defects, meningomyelocele, and then splenic dysfunction. These are some common risk factors which we see in case of children having meningitis. So when you take a history, you have to cover up all these factors. Now come to pathophysiology. So first, I have mentioned in very simplified form. So first there is colonization of the pathogens in the nasopharynx. After that it breaches the mucosa and enters the circulation. After this it gains entry to the CSF through choroid plexus vessels of the lateral ventricles or the cerebral blood vessels. Here in the CSF it multiplies very rapidly because CSF have inadequate defense mechanism like complement, antibody, neutrophil. Comparatively this is low. So multiplication of organism is faster since the defense mechanism is less. And then after that, after multiplying, it stimulates the inflammatory response, producing inflammatory mediators. So the common inflammatory mediators are interleukin-1, neutrophil, tumor necrosis factor, chemokines, glutamic acid. So after this, the inflammatory response will activate the complement system where the free radicals are released, and this is responsible for increased capillary permeability leading to cerebral edema. And this alteration of the blood-brain barrier and vascular thrombosis occurs leading to brain damage. So in meningitis you see the brain injury is one is due to the bacteria itself, its toxins, and then second is the host reaction to the inflammatory cascade, how they are reacting. After the inflammatory response, they are releasing the inflammatory mediators and activating the complement system. So by these two ways, there is brain injury in meningitis. Now let's move on to clinical manifestation. So the classic presentation will be fever, headache, vomiting and photophobia. Whenever a child comes with a fever, headache, vomiting, always keep meningitis as one of the diagnoses in your mind. Then the patient may complain of neck stiffness or some rigidity, and there can be bulging anterior fontanelle in case of younger children and signs of meningeal irritation in the older children. And there is altered mental status, which may be presented as lethargy, confusion, irritability, delirium, stuporous and coma. Now let's see the signs of meningeal irritation and then how you are supposed to elicit also. So neck rigidity, flexion of the neck is painful and limited. So when you are doing a passive flexion of the neck, it is painful and limited. Carnic sign, you make the patient lie supine, then flex the hip at 90 degree and extend the knee. The extension of the knee is limited to less than 135 degree. That is due to spasm and pain in the back of the thigh muscles. So that condition is known as Carnic sign. And Brudzinski sign, when neck is passively flexed, knees are automatically flexed. So all these signs of meningeal irritation is absent in the younger children, infants. Less than 18 months to 2 years, you will not get these signs as the myelination is not yet completed. So in the picture you can see Carnic sign and Brudzinski sign. So Carnic sign, you flexing, patient is lying supine, flex the hip at 90 degree like this and try to extend the legs. It is limited, there is no fully extension. Then when you are doing passively neck rigidity, the legs are automatically flexed this way. So if it is occurring like this, you say this Brudzinski sign is positive. Okay, same, this is Brudzinski sign. Look at the legs, it is getting automatically flexed when you are passively flexing the neck. Okay, now symptoms based on different factors, like symptoms of increased intracranial pressure will be headache, projectile vomiting, bulging fontanelle in younger children with the widening of the sutures. Then there is altered mental status, irritability, drowsiness, confusion. There can be papilledema and blurred vision. So always do a fundoscopy before you do a lumbar puncture. Then focal neurological signs with a 6th nerve palsy can be seen. And late sign of increased ICP will be Cushing's triad or the reflex. This indicates impending brainstem herniation. So if this condition is there, you should not do lumbar puncture, that is contraindicated. So this triad is bradycardia number 1, number 2 hypertension, where they have a wide pulse pressure due to increased high systolic pressure and low diastolic pressure. And there is irregular respiration. There can be apnea or there can be hyperventilation. Then features of altered sensorium, seizures indicate there is parenchymal involvement. And in the parenchymal involvement, you get a focal neurological signs and coma also. And there are some extra CNS manifestations which presents with the rashes, like this with the petechial rash. There can be arthralgia and then there can be shock and DIC. Especially meningococcal meningitis, it presents with these features. And meningitis, the clinical features of meningitis in the neonate and younger infant is different. So they may present with the vacant stare. They present like a sepsis. So they have features of sepsis like hypothermia or fever. They are lethargic, persistent, vomiting can be there, refusal to suck, poor tone, poor cry, shock and circulatory collapse can be seen. And there can be alternating irritability with a drowsiness. There can be convulsions, persistent bulging fontanelle. So these will be indicating this neonate may have meningitis along with sepsis. And then more risk is seen in premature babies, low birth weight babies, prolonged rupture of the membrane if the mother is having if there is a maternal sepsis. And babies who are under intensive care unit, they have a high chance of having meningitis. Now, special features with the special organisms. So if you know these features, it will help you to suspect the organism and start your antibiotic or the treatments. So Haemophilus influenza B is occurring in 80 to 90% cases between age 1 month to 3 years. So beyond 3 years, chances of Haemophilus infection is less. Pneumococcal meningitis is usually following otitis media, sinusitis, pneumonia or head injury. So if meningitis is occurring with these conditions, then you can suspect pneumococcal meningitis. And both Haemophilus influenza and pneumococcal meningitis are very common in unimmunized children. And then subdural effusion, convulsions, residual auditory deficit or hearing loss is common complication for both organisms. Come to meningococcal meningitis. This is a different type of meningitis. If you see meningococcal meningitis one time in life, you'll never forget. So the presentation is like that. So presentation can be hyperacute. There is rapid onset of fever with the purpura, petechial rash, DIC and altered consciousness, which you will not see in other meningitis. It is acute fulminating illness, presents with the adrenal insufficiency. There is adrenal hemorrhage and there is necrosis of the adrenal gland. So you get all features of adrenal insufficiency with the hypotension, shock and coma. So this condition is known as Waterhouse Federation syndrome. This is a life-threatening complication of meningococcal meningitis. And this meningitis occurs in crowded areas. Sometimes it can be chronic form, but it is rare. So if it is presenting in a chronic form, then it presents with the intermittent fever, having chills, joint pains, maculopapular rash, hemorrhagic rashes. So if a child is coming with a recurrent features like this, then you have to suspect meningococcal meningitis or meningococcal sepsis. This is rash of meningitis, which is petechial purpuric rashes. Ultimately, this might change into necrotic rash and sometimes gangrene also. So which may lead to amputation of the parts of the body. So meningococcal meningitis, if you treat in time, it may be cured without any sequelae or complications. But if you can't treat in time, then it might lead to mortality also. Now come to differential diagnosis. Meningism, the inflammatory cervical lesion and apical pneumonia may lead to meningism, that is, especially the neck rigidity you get. Partially treated meningitis, aseptic meningitis, TB meningitis and viral encephalitis all comes as a differential diagnosis for meningitis. Okay, thank you. I hope this class was useful for you all. If you find my class helpful, please like, subscribe and share. Next class I'll discuss on the lab investigation and treatment and complication of meningitis. Thank you.